Good morning, everybody. Thank you for joining. Um, I'm Jamie. I'm the pediatric clinical educator at UMC. After the presentation is completed, we will post the link in the chat to claim CE credit. This presentation is some pediatric education over pediatric emergencies and some other pediatric specific care in the emergency center. If at any point you have questions, please feel free to stop me. I also have the chat up, so I'll try to keep an eye on it and try to answer questions as we go. I'm not going to read the agenda, but this is just kind of what we're looking at today, some pediatric specific resuscitation and management, airway, vascular access. So we'll start with weight-based calculations. In pediatrics, the most critical thing when considering care for a child is getting an accurate weight in kilograms. Everything is based off of the weight, so the vital sign parameters, medication dosing, all the code meds. And so getting an accurate weight in kilos is important. Pediatric readiness actually recommends to get rid of all pound-based scales and options on scales to prevent accidental weights in pounds versus kilograms. For all kids, if you need to weigh the child and the child won't stand on the scale or won't sit, you can weigh the parent and weigh the child together and then subtract the kid's weight from the parents. And that will ensure that you've got a decently accurate weight of the child by themselves. One beautiful thing about a Broslow or a length-based estimation tape is even if you have a weight or you don't, whichever one, it has the appropriate sizes of equipment and everything else on it. So it has your code drugs, but it also has like your urinary catheter size, your chest tube size, your NG tube size, even your vascular access size, so that there's no question. If you have a 20-kilo patient, you can go to the 20-kilo section on your Broslow tape and know exactly what size you need of everything versus trying to guess or to try to figure it out, just on your own or having to know everything. So it's a really great resource. Tylenol and Motrin are two of the most important concentrations that we give out in the ER. A super quick tip is whatever your kilos are, if you have that will be the dose in mils you'll be giving to the child. So if the kid is 10 kilograms, if you divide that by 2, you'll be giving 5 mils. I think that fever and untreated temperatures are one of the most reoccurring visits here in the ER. So being able to give them that Tylenol and Motrin dose and giving them an accurate schedule of when they should take it and which one, and throughout the night and throughout the next day to really help break that fever is very, very helpful. It also coordinates to like tablets. Every 5 mils is 1 tablet, and so you can half the kilos and then you can give them the appropriate amount of tablets that they should take as well. When it comes to vascular access, I think this is really hard for people that don't see kids a lot. It's very difficult in figuring out what size catheter is appropriate. We see a lot of patients from outside facilities that have catheters that are very large, like 20 gauges or 18 gauges, and kids that probably don't need it. So CHOP has this really cool catheter sizes based on age. It is also on the Broslow tape. But as you can see, up until the age of, 13 plus, they don't really need bigger than a 22. Even up until 14 or 15, most of the time a 22 gauge will suffice for getting us the things that we need, whether it's antibiotics, CT scans, MRIs, whatever it is that we're doing. Most of the time a 22 is more than adequate. When you hit that 50-kilo range and you get above that into like that 70, 80 kilos, sometimes the CT scanners or the people that are doing CT scans won't move forward with the scan because they need a little bit bigger line. So that may be when you get into that range of needing to, get a bigger line. This also has the central line French for cordis and for traumas and arterial catheters as well. It's not super common in the outside facilities to do that, but it's on there. The next, this is the mils per kilo. I think this is also really important. Sometimes it seems like we're taking so much blood in a single blood draw. We may be taking multiple tubes and it seems like so much, but it's really just half a mil to 2 mils, which helps. So this chart kind of gives a little bit of idea of how much we can take. Most of our patients are going to be above that 8 to 10 kilo range, and so we won't get anywhere near taking 30 to 40 mils of blood, or we shouldn't at any point. So even though it seems like a lot, we shouldn't reach this. On our smaller kiddos, it's really important to document and to keep track of how much blood we're taking, so that we can make sure that it's not too much at a time. In our facility, we have what's called a DIVA team. It's direct intravenous access team. This ultimately is using ultrasound guided IV capabilities for access. It just helps us look on the inside and differentiate vein versus artery, and it gives us a lot better first time success rate. It also has longer longevity because they're deeper vessels. The problem is it's kind of a slow process. You have to be very patient, and you need staff training and competency follow-up. You also need extra hands for like positioning and stuff, but it is a fantastic skill. We have really grown our team here, and it has really helped like getting vascular access on kids. When it comes to pediatric assessment, I think one of the most important things is if you can't see them, you can't perform an accurate assessment. So right now we're in summer, so there's not a bunch of coats and jackets and blankets, but we're making sure that we're removing all obstructions to be able to see and fully assess the patient is very important. When we're looking at the pediatric assessment triangle, we're looking at appearance, work of breathing, and circulation. We're looking at how the kid looks when they present to the ER, what their overall appearance is before we ever even talk to the family or get a story, quote unquote, on what's bringing them in. Using the pediatric assessment triangle and viewing them from across the room is going to tell us the story, especially if we've got multiple patients waiting. We're going to be able to pick out which kid or which patient needs to be seen first. If you have different disruptions in the PAT, you categorize them sick, or sickest. This is a TNCC and ENPC type thing. If they have no disruption, then they're considered sick. Any patient that comes to the ER is considered sick because the parent believed that there was a reason to bring them in. Our sicker patients are one component is disrupted. So one of the three, maybe the patient is pale, then they move into sicker. And then sickest means two or more components are disrupted. Those patients are the ones that we want to keep an eye on, and we want to try to get back and seen as quickly as possible. AFPU is the other portion of, triage and pediatric assessment, really for every patient, not just pediatrics, but it's looking for how the patient reacts to you when you're speaking to them. Are they awake and responsive? Do they only respond to voice? Do they not respond at all? Or are they unconscious? This will give us a really good idea of what we're looking at triage-wise. When we're considering the pediatric assessment, altered mental status is should always be taken seriously. When you're first considering altered mental status or a patient that may be unresponsive or has an altered LOC, the two things that we should rule out first are hypoxia and hypoglycemia. They are the first two and the easiest to treat. So place oxygen on the patient even before they're on the monitor and get a blood sugar. If that fixes our altered mental status, that's easy. We did some very minimally invasive procedures and it fixed them. That's good. If it doesn't, then of course we know that we have to dive deeper into what's going on, and we can do the more invasive things at that point. When we're considering triage and vital signs or pediatric vital signs in general, one abnormal vital sign should increase our acuity, and two abnormals should absolutely increase our acuity. At that point, we're a high-risk situation. We should be cautious with documenting outrageously high blood pressures without intervention, because then it looks like we didn't treat like a hypertensive crisis, when in reality, the patient was just moving and crying. Placing nurses' notes stating the patient was moving and crying and trying later is within our policy. We have it in our policy that we notify the provider if it can't be obtained after 2 attempts, and then we just try later in the visit. Hypotension in kids is kind of a big deal. I think that sometimes we look at kids and we don't think that they can have the same ailments as adults, and so it gets overlooked, but hypotension should always be documented. It should always be notified to the provider. And then having the appropriate size manual cuffs in our facilities is important as well, so that if we recognize hypotension, then we can get a manual blood pressure and verify whether that's correct. We can also try it on a different extremity or something like that to see if maybe it's just the cuff or where it is, but we should take that seriously. In these kiddos, we kind of have some danger zone vital signs. So in our facility, we have it in policy that all patients 3 months or less have to have a rectal temperature as the core temperature is the most accurate. All the rest of our patients get tympanic temperatures. We do have temporal thermometers, but that's reserved for the kids that don't have anything related to fever. So like you fall and break your arm, you get a temporal. Everything else is tympanic. So a temperature greater than 102.2 in any age of child is concerning. I would say that with all these new viruses and even like the historical viruses that we've had forever and ever, it seems like more so recently, temperatures are getting higher and higher. We're seeing those high 104s, we're seeing the 103s. And so a threshold of 102.2 doesn't seem high, but it means something is going on. If the infant is less than 90 days and the temperature is greater than 100.4, that's a big red flag. We have got to intervene and act decently quickly on those kiddos, especially on the kiddos that are less than 28 days of age. Those patients are going to need a lot more intervention, a septic workup. And so getting that rectal temperature, getting an accurate set of vitals and assessing the patient to see what their tone is, how they're acting, if they're acting appropriately, are they eating and drinking? That's all important because that's going to determine our plan of care and how we take care of the patient. In that same regard, hypothermia in pediatric patients is also very concerning. If the patient has a temperature less than 95, we should be very, very concerned. We should be thinking about all the things, thinking about sepsis protocol, antibiotics, because this means that the patient's body is no longer compensating, and we need to intervene and get them taken care of very quickly. In a neonate or an infant, a temperature less than 96.1 is also very concerning. We should treat that the same way as if you're treating a high temperature. So high and low both get the same type of treatment, which is a full septic workup. The other thing to consider in pediatric assessment is injuries. So in patients less than 5 years of age, really all age, but less than 5 is kind of our target area here at UMC because they can't speak for themselves. But we should be doing abuse screening when those patients are brought in. We should see if the story is consistent. Was the injury witnessed? Does the injury match the story? And then does the patient's age match the injury? And can they developmentally like perform or, do the injury that occurred? I think it's very critical in the ER when we're first seeing these patients to do these screenings and to make sure that we're properly looking for abuse and making sure that we're ruling out kind of all those things. It doesn't mean that you should be thinking every patient that comes into the ER with an injury is being abused, but we should be watching for those telltale signs or the signs that aren't usually there. That delayed care, happened 5 days ago and they're just coming in to be seen and it's obviously deformed. Things like that, or multiple recurrent visits. It's very important to take a look at that. Summer is very difficult with abuse because the kids are home, the parents are tired, the kids are being quote unquote annoying and they're loud, and so it just really increases these risks of abuse at holidays in the summer. And so it's important that we're very vigilant in paying attention to this. When we're talking about respiratory and airway considerations, pediatric airways are a lot different than adults. They've got that big old head, they've got the small mandible, they've got a big tongue, and then their airway is smaller in diameter. So it's very easy to accidentally obstruct that airway or obstruct it with things like foreign bodies or whatever else, the patient puts in their mouth. The smaller the kid, even bigger kids, even teenagers put things in their mouth. Like coins. I think here in summer, coins and foreign body airway things are a big deal because they constantly have things in their mouth. They're just, they're sucking on it, or they see it on the ground and they pick it up and they put it in their mouth and they swallow it. But it's just hard because their airways are not set up the same way as an adult. Um, I will say we've had some very interesting foreign body aspiration type things you don't even think about, like duck squeakers. There is lots of things that kids can be chewing on and accidentally swallow that you wouldn't consider. And so talking to these families and making sure that they understand to put things like that up or to keep them out of reach is important.
You got about 15 minutes until 9, so I would.
Sorry, y'all. So airway positioning, I love these images because it shows just how easy we can compromise a pediatric airway. So if you look on the far left where it says A and B, that roll underneath the patient's head, you can just see how the airway is closed off. But all it takes is a shoulder roll and the airway is nice and open. The same thing in the middle, you can see the sniffing position where you pull the chin up, bring the nose to the air, get the shoulder roll in place, and it shows how open the airway is. It's especially important in these neonates when we're doing sepsis and we're thinking about LPs and stuff like that, because we can accidentally compromise that airway and obstruct it unintentionally, which has now created a new problem on top of the other problem that we already have. So it's really important to ensure proper positioning. Also remember when we're placing C-collars and stuff on these patients, that we still want to maintain appropriate airways. But we don't want the C-collars to be too big because then they can also potentially compromise the airway. So for pediatric respiratory assessment, your standard things are the same. So your work of breathing, all of those things. But there's some extra things that we have to pay a little bit more attention to when it comes to kids because of just who they are and what their airway, and they can't always tell us what's going on. When you're considering mental status and GCS, it's important to ask the family, what is the baseline for the patient? Like, what is their normal mentation? Um, how are they acting compared to their everyday life? Because not every kid is the same. They may not meet milestones the same, or they may be nonverbal, or they may be all those things. And so assessing their activity, their movement, their tone, what their everyday life looks like is going to be a little bit different. Looking for upper airway obstruction, listening for sounds. Kids often, it's a lot easier to hear those adventitious breath sounds like stridor when they walk through the door than it may be in an adult. Kids also compensate really well until they don't compensate anymore. And so it's important to kind of put all these things together. The other things that are important to ask is what their intake and output has been in the last 24 hours. So how many wet diapers have they had? How many ounces of formula? How many times have they breastfed? Because that is all going to go to their dehydration status. And then assessing their capillary refill and their fontanelles. In triage, that is something that we should be assessing on every patient. As you're getting, a blood pressure, go ahead and check capillary refill in that moment so you have an idea of what it looks like. Feel their fontanelle as you're doing your assessment or you're asking their questions just to see kind of what it feels like, if it's bulging, if it's sunken. All of these put together with your normal things, how your lungs sound, how they're breathing, all of that will kind of tell you a story about their respiratory assessment. These are the late signs of a respiratory emergency. So if we're already having skin color changes, like they're becoming cyanotic or mottled, if they're becoming lethargic and flaccid, we have already lost this game. Like now we're progressing into immediate airway interventions versus having time to, kind of fix the things that are broken. Positioning is also super important. Even though they're kids, they will assume the tripod position and other positioning to try to make them be able to breathe better. Once we've moved into bradycardia and restlessness, just like an adult, like we should prepare for the worst because it's coming. I like this diagram because it talks about respiratory distress and respiratory failure. When the patient is in distress, they're tachypnic, they're coughing, they're retracting, they're assuming those tripoding positions or other positions and they're labored, they're compensating. And for some reason at home, they compensate until they just crash out. And so that's why the black line is so long, is because they're going to compensate for a long time. Then they're going to get here and they're gonna, if we don't intervene immediately and get them taken care of, they're gonna move swiftly into respiratory failure, and it's gonna be a swift, rapid decompensation. They may get where they're not breathing well. They are not going to be coughing anymore. They're not going to be retracting. They might start having a decreased LOC or activity or lethargy. And if we're not paying close attention and we're not keeping an eye on them because maybe the rooms are full or something else, then this could happen very quickly and progress all the way into respiratory arrest. And now we're in a whole different situation. You know, we may have a cardiac arrest related to respiratory arrest or hypoxia and apnea. So we've created a whole nother issue that we're having because we didn't catch it when we were in that distress area. Um, they work harder and harder to breathe. Like it progressively gets worse and worse until all of a sudden it seems like they're getting better. If for some reason the patient is sitting there and you're thinking, wow, they're actually looking better, that should be a red flag to you. If you've done nothing and you've not intervened, you don't have a place to take care of them, and they start looking better, we should be concerned and we should get that patient seen pretty quickly. When it comes to airway and assessing pediatric patients, the question to ask is, are immediate life-saving interventions required to sustain life? So is intubation necessary? Is a patient apneic, pulseless? Do they have a low pulse oximetry reading less than 80%? Or if they have EKG changes, unresponsiveness? So kind of that AVPU, that P and U on the AVPU, that should tell us like we need to intervene pretty quickly. When we're discussing intubation, we have this chart, and I actually really like it because it's kind of like a Broslow chart. Even if you don't have a Broslow cart, this chart can help like look at the patient's weight in kilos plus their age and gives you everything that you will need. What mass size, your ET tube size, your stylet color, your blade, your NGOG size, LMA, your glide scopes, everything. And it just kind of puts it at a quick glance on what should I need for this size patient. Remember, it's also on your Broslow tape. But sometimes it's hard to look at your Broslow tape when you're trying to pull meds for RSI or whatever else, or resuscitation. Having this airway by Broslow is just another quick, easy reference. When we're talking about respiratory failure and respiratory arrest, we have to consider any underlying conditions, things that they're treated for at home, medical illnesses, medications they take, or are they following their treatment guidelines? So let's say they have asthma. Are they following their asthma action plan? Are they taking their controller meds? Are they taking all of their normal everyday stuff, or are they not? And that's why we're in this position. It's also important to ask any previous need for intubation and previous hospitalizations related to the same complaint. If this is the 10th time they've been hospitalized and the 5th time they've needed intubation, we should be preparing more quickly than if we weren't having the same conversation. So for resuscitation and fluid and electrolyte management, PALS has the best algorithms. It is very easy to print these and have them accessible so that when you're talking about, cardiac arrest, any cardiac arrest in a child is going to be very difficult. But if you don't do it often, it's even more difficult because it's very scary. And thinking about doing this or that right is more difficult when you're in a high stress environment. So having these algorithms ready and accessible in those quick moments is very important. What I love about these algorithms is not only does it talk about CPR quality, because a lot of facilities have gone to like RQI. So instead of going to a class, going through PALS and ALS and BLS, like we're doing it online now, which is nice because you're doing it quarterly, but you're not getting all the extra quote unquote information that you were getting when it was class time. So it has kind of what your CPR quality should look like for a child, how far you should push, what your time, your 100 to 120 per minute, and then what your advanced airway versus no advanced airway looks like. It also has your energy or your joules for defibrillation. I think this is extremely important to know. Most of the time we rely on what does the physician want, but having this as a quick reference. Sometimes our physicians in our more rural facilities don't see kids but every once in a blue moon, and so they may need a refresher or a second opinion or a second guess. Also remember that your joules are on your Broslow tape. So you can refer to it there as well. It talks about advanced airway and then your drug therapy. I love that the drug therapy is on here because it's a fantastic reminder, especially in those moments, of what your targeted medications or what your targeted drugs are in pediatric cardiac arrest. So what your rhythm is, what you should do next, when you should give it, and then what your adjunct medications are. Also remember in cardiac arrest, your H's and T's, so your reversible causes. As you are looking through these things, all of these things are important. So managing hypoglycemia, hypo or hypokalemia, hypoxia. We're doing an ABG or a BBG for acidosis, replacing volume. If we have a pneumo or cardiac tamponade, if they've ingested poisons or toxins, and then if there's any type of thrombosis. The other three I want to include with this are lines and drains, connections, and sedations. Those are the other like top three things that we should be checking if the patient is either hasn't been in arrest and is now, or is moving towards arrest after being, say, intubated. Always check your connections. Follow them from one site to the next to make sure that there's no kinks or that nothing's unplugged or that everything is nice and secure the way it's supposed to. That includes your ET tube connections. That includes your cord into the wall, your suction, and then sedation. One of the most common causes of pediatric patients, desatting or having tachycardia or bradycardia is either being undersedated or the ET tube tip hitting the patient's carina, and that will cause them to be bradycardic. So pulling that tube back and giving them a little bit of extra sedation, making sure that they're not paralyzed and hurting is extremely important. So double checking those sedation medications and giving a little bit extra if you see those changes in vital signs. The other PALS are, algorithms are a patient with bradycardia, and on the right it's tachycardia. This also has kind of all the possible causes and then the medications that you will need. Note that on bradycardia, all your supportive cares too, so like your ABCs, putting on oxygen, getting a 12 lead, seeing if there's any of those H's and T's that we talked about in the previous slide to kind of help this. If your patient's intubated, is my tube too deep and it's touching the carina and that's why I'm going bradycardic? Or is there something else? Did the patient take a medication or overdose on a medication and now they're having bradycardia that we need to treat with something else? Also remember with bradycardia that even though it's a pediatric patient, pacing is still an option. We're going to try other things like epi, even quote unquote push dose epi, those smaller epinephrine doses, and atropine first. But if the patient remains bradycardic, we may have to pace them to prevent them from moving into full cardiac arrest. Remember, when we are pacing, you've got to get mechanical and meaning you have to see it on the monitor and you have to feel the pulse to make sure that you're getting enough juice to actually get the heart rate to where it should be. For tachycardia or SVT, depending on if it's SVT or not, we have to consider synchronized cardioversion. In pediatric patients, most of the time, as long as they're stable, we're going to try other options first. So vagal maneuvers, ice to the face. We had a physician in PICU when I worked there that would do rectal stimulation in smaller babies to help them like vagal down and stop the SVT. Now, that's not reality in your big patients, but there's also other things like leaning them back very quickly and putting their feet above their head. So there's lots of options we can try before we move into adenosine or synchronized cardioversion, but those are all options for a stable patient. If we have an unstable patient, we have to move to these other things very quickly. While an EKG is really lovely to have, if you don't have quick access to it, leave it for later. Do all of the other things first. Get the patient in a room, on a monitor, get somebody in the room, get a physician there, get IV access, do all of those things, and send somebody else, send your tech or whoever else can go get your EKG for you, so that you can get that taken care of. One of the most common reasons that a patient who has had SVT previously goes back into it is either lack of increase of medication dosing, so not getting the appropriate increases in meds from the physician based on weight, or just non-compliance with therapy. They think that their child doesn't need it anymore, so they stop giving it. And then now we're back in the situation. It's very important in these situations to ask history, ask about a NICU stay, or all of those things to see if they've had this in the past. When we're giving a denizen, the stop cough method is the best way to do it. The half-life of this medication is so rapid that if we don't appropriately push it in fast and IV slam the flush behind it, it's going to be very difficult to get the proper like what you want out of the medication. So the current guidelines, they're changing a little bit. In adults, they're going to go to 12 and 18 versus 6, 12, 12. But currently the guidelines for pediatrics say 0.1 mg per kg, rapid bolus up to 6 milligrams, with the second dose being 0.2 mg per kg up to 12. And you can give that second dose for one more time. So you can give one 0.1 and two 0.2. And then, of course, if you have to move to synchronized cardio version, we're starting at half to 1 joule per kg. You can increase all the way to 2 joules per kilogram. There are two things that are super important. Try to sedate the patient if possible, if they're stable enough. Obviously, don't give them propofol if they already have a low blood pressure, or don't give ketamine if we're going crazy with hypertension. But maybe try some Versed or something like that. And then the second thing is ensure somebody is watching the parent. When you're getting ready to shock and you're clearing, they hear that and they see everybody let go of their child, and they immediately rush in to put their hands on it or to comfort or to touch their child. And it increases their risk of getting shocked. So make sure that somebody is watching that family member very closely. When we're discussing pediatric electrolyte replacement, there is this formula based on what the patient's weight is, and this is kind of it just laid out according to kilograms. But then if you want a fluid, like an hourly rate for 24 hours, you just multiply it by 24 to get the total mils for the day. But it's important to double check and make sure that we're giving the appropriate amount of fluid resuscitation, because kids lose sugar very quickly. So as they're in distress, as they're working hard, as they're, stressed out, they're going to be really burning that sugar off. So if we don't replace it, then we're going to get ourselves into a worse situation. For maintenance fluids in kids, the most common are kind of like the top two. They're switching a little bit away from the half NS portion and they're moving into D5NS. But it depends on the facility. For our smaller kiddos, sometimes they use a quarter NS, but it always has potassium in it, usually the 20 milliliter equivalents, and then it has the D5. For resuscitation, we're going to only resuscitate with NS and LR. If we have hypoglycemia, then we can add in D5 or D10 appropriately, but we're not going to resuscitate with that D5NS or anything like that. We want to make sure that it is just straight normal saline or lactated ringers. In our normal, like children, usually above that 6-month range, we'll do the 20 mils per kg, reassess, and you can give another if you need it. In our infants and neonates, we're going to start with 10 mils per kilogram and then give another one if we have to. Most of the time with LR, we're not going to use it in those teeny tiny infants. We're going to stick with NS. And then of course you've got like your neuro patients that need 3% hypertonic saline. If they've got cerebral edema or head trauma, it is a high risk medication. There's very strict guidelines around that, so just be cautious with giving it. There's lots of emergencies that can come into the pediatric EC or into the EC in general, but these are just some kind of common ones. Respiratory failure, seizures, anaphylaxis, dehydration, poisons, aka sepsis, psychiatric crises, and foreign body aspirations. I would say the most important thing is doing that assessment, assessing that patient when they come in, and then intervening based off of that. A lot of these things, if you look at them together, they kind of overlap. So you may think that it's wheezing, so you think the patient's having an asthma attack, and the next thing you know, they pop up with hives. And so your treatment is going to be the same for certain things. Like you're going to work. There's a lot of the algorithms and the treatments and things like that that really overlap with each other. And so you may be doing the same thing over and over again for different types of emergencies. Having administering antibiotics within 60 minutes of order or of arrival is extremely important. I think we do really good about sepsis management in adults, but we don't always think about it the same way in kids because it's a kid. But in any patient, getting antibiotics in within a certain amount of time, 60 minutes is ideal, is really important. The other important portion of that with antibiotics is open fractures. If you have a patient that is here for trauma and they have an open fracture, we should really try to get those antibiotics in within 30 minutes. Depending on how the fracture occurred, there's lots and lots of bacteria and things that can get into that. So getting that treated before it gets out of hand is important. And also on the back end, teaching the family, if this happens again, this is what you do, so that as we move forward into this, let's say it's DKA. When you first enter the ER and you get a new diagnosis of DKA, you're not going to be super open to teaching because you're going to be shocked and concerned about what's moving forward. But constant education and constantly reassuring the families what they should be looking for, what they would do the next time is important. And then having all the supplies that you need. So different oxygen supplies, airway support, medications like benzos, epi, all of those resuscitation medications are important to have on standby in case that happens. And then, of course, trauma. We're here in the summer, and so trauma is a big deal. ATV accidents are crazy right now. MVCs, scooters, like there's so many things that are very trauma heavy. Um, so these are just a couple of different like trauma mechanisms that we've seen. Burns are really big, especially here at 4th of July. But here's just some like key signs, some concerns, and then some actions. I will say that on most of these patients, the action is the same. They're going to present to the ER. We're going to do our primary and secondary assessment. We're going to obtain things like a FAST exam, X-rays, CT scan, intervene, and do the things that we need to immediately. If you're in a rural facility, you're going to get the patient stabilized and transferred to a high level of care. If we're here in a big facility like we have, we're going to get them stable, do the most that we can, and then transfer them to whatever unit they need to go to. I mentioned it earlier, but that non-accidental trauma or abuse is really important to double check and to take into consideration right now. We want to make sure that we're assessing that even on these like injury patients. Remember that CPS isn't just for bad things, quote unquote. If a patient is non-restrained in a car seat because the family can't afford it, CPS can help facilitate that. In facilities like ours at UMC, we have car seats and stuff that we can provide to the family, so they shouldn't go home not an appropriate car seat. You don't have to go out and put them in the car seat, but you should be asking those questions and making sure that they have the things that we need. And then just taking a look at the burns, making sure that we're doing appropriate fluid resuscitation, making sure that we're getting appropriate IV access. Remembering that if you can't obtain IV access within a couple of times, moving to IO, even though the patient is a child. And then just making sure that we're keeping an eye on our fractures and dislocations, looking for any type of extra swelling or hematoma formation. And then just keeping an eye on the other things. What does our LOC look like? Are we getting worse? Performing an appropriate abdominal assessment is very important, especially after MVCs. Remember that just because EMS doesn't see it on scene doesn't mean that it's not going to be there. Your assessment should be your own. Don't trust that they don't have seatbelt sign just because somebody told you they don't. You should be appropriately looking and assessing the patient yourself versus trusting somebody else's assessment. Last but not least, family centered care and communication. So this is just a little table of kind of age appropriate things. So for all patients, we should be using a calm tone. We should make sure that we can talk to them in a developmentally appropriate age. So I'm not going to come in to a 3-year-old and say, do you have abdominal pain? I'm going to say, does your belly hurt? Or you're going to tickle them or whatever to see if they wince or if they laugh or if they cry. Making sure that you get down on their level. I always call us like the Jolly Blue Giants or like the Smurfs because we come in and I'm just towering over you and I'm scary. But if I get down on their level and I bring them in some stickers or a toy to play with, it's gonna make them a lot more prone to kind of answering my questions or doing the things that I need. Make sure that we offer choices, but we don't lie to them. So don't tell them this isn't going to hurt when you're going to do an IV. It's going to hurt and you know it. So just be truthful. Don't scare them and be like, this is going to hurt so bad, but also be realistic. You don't want to lose trust in them because you tell them something that's not true. And then always make sure the family is included. The parent is going to be your best resource. Ask them questions, get them involved in the things that you're doing. Make sure that we're giving clear explanations to both the family and the patient. Don't just talk to mom or dad and never include the 5-year-old that is in the ER wondering what the heck is going on. And then with those adolescent age, make sure that we offer privacy. If we're asking, the questions that are very difficult for those kids about periods or sexual like things, make sure that it's in private so that they don't feel like they have to not say it or not disclose it because they're worried about judgment and decisions. I also think it's really important to tell them, like, I don't care what your answer is here. You're not going to get in trouble, especially when we're asking about like drugs and alcohol. I think they get so nervous that we're here to, call the cops and get them in trouble. And just letting them know that like you're not in trouble here. This is a safe space. We're here to care for you. We're not here to get you in trouble. The other things are, building trust, making sure the patient doesn't have any extra anxiety, making the family feel connected and care, having those difficult conversations, and then ensuring that we have caregiver support during emergencies. So introduce yourself, involve the kiddo, make sure that they're a part of every decision that you're doing and that they're aware of what you're doing prior to what's going on. Making sure we distract them, use games, movies on the TV, a cell phone to watch a movie, or if they have a favorite toy, including them. One thing I love to do is if they have a little bear or something, I like to kind of, I'll put Coband on the patient's arm if I'm going to do an IV and let them know that their bear or their baby is the same as them, so they don't feel like they're left out. If you have child life in your facility, it's a great resource to use. Um, and then getting the family involved, letting them hold them when they can, letting them be at bedside or be, in their face to kind of help hug them or comfort them. But when we're having difficult conversations, be very clear and honest. Don't beat around the bush. Don't say things that are, could be misinterpreted as something else. Um, when we're having those very, very hard conversations or we're disclosing difficult news, like they need to hear it the way it is because we don't want them to have a question or to think that we mean something else and have to explain it all over again, just to kind of like reinvent the wheel. Just be very clear and concise. When we're talking about family presence in emergencies, we have to make sure that there's a safe scene. Um, Before we call a cardiac arrest here in the EC, we try, depending on the situation, there are some situations where we can't, but we always try to get the family member in there before the room is sealed. Because as soon as CPR stops, most of the time in a child or an infant death, it's going to become an ME case. And so the police officers on scene are going to seal the room, and that means nobody can come in or out. So if we want that family member, that mother, that father to have a last opportunity to see their child before they, go to the funeral home, this is kind of this is the only option. So we will sometimes hold off on stopping until we can get the family in there. Um, if they're very disruptive or if their distress is interfering with care, obviously we don't want to put them in the middle. Like our priority is taking care of the child, but studies have shown that it is very important for families and parents to see that everything is being done, especially if it's a freak accident or it's something that could have that like is either preventable or unpreventable. So for example, drowning. It's very, very important for that family member for their closure and their long time recovery to see that everything was being done. Um, and then, of course, make sure somebody is with them and available. Don't just leave them in the room alone. They need somebody that can help explain or, keep an eye on them, make sure that they don't, sorry, that they don't have that they don't go down in the room, that somebody is just keeping an eye on them to make sure that they have support that they need. It does, like I said, reduces their future trauma and anxiety for the family if they're allowed to be in there. They get to witness, that we're doing everything that we can, and then it helps us communicate. These conversations are already difficult. Telling a family member that their child has passed is something that nobody wants to do. But when they see that it's happening and they see that we've done everything, it's easier to cope long term. And so it's really important to get them in there, if at all possible, so that they can kind of have that closure that they need. Um, and then assign somebody to support them, making sure that they're getting those updates, they have emotional support, and that they're safe in wherever that they are. Um, the aftermath of pediatric death and investigation is very difficult. If you've never experienced before, even as a nurse that, doesn't know the family, you've never met the child before this, the distress that the families are under while they're being interrogated, while the medical examiner is coming in, while they're taking pictures, while they're doing all this, it is very, very distressing. And so I say, take care of yourself, not just the family. Explain to them like what's happening, why we're doing things the way that we're doing. Give them the option to have a safe place to sit, so a family room or a different patient room, and then make sure they're out of the way so that we can still do what we need to do. We're still caring for the child until the last moment. If it's called or we obtain Ross, we still have to make sure that we can appropriately care for them. And then for healthcare providers, make sure we debrief after the event. Talk about the situation. What went well? What did you need that you didn't have? What would you have done different? Like what maybe you needed a different medication or a different concentration, or you needed something that would have made your job easier in that moment. Debriefing is the best, right after the event is the best opportunity to make sure that everybody gets to say their piece and gets to discuss what they needed and make sure that we get all the supplies and stuff we need. And then make sure that there's lots of CISM resources and stuff that can help take care of yourself. Working in healthcare, working in the ER is very difficult. We see a lot of bad stuff. We see a lot of things that normal quote unquote people that aren't healthcare providers see. So taking care of yourself is also very important. When we're documenting this, make sure that we document whether the family was present. And if they weren't, family not available, RN attempted to locate family, family not available. And just kind of document the stuff around that they were at bedside or they weren't, or just make sure that it's included in the documentation. And then of course, if there's anything that's relevant to the patient, then we need to document it. So we want to make sure we have an accurate triage assessment, an accurate physical exam and stuff like that, because that will contribute to the care of the patient. I got done a little bit early. That's all I have. Does anybody have any questions? Or anything I can help answer? I will stick around for a few minutes. Kelsey will post the CE in the chat. So if you guys want CE credit, please scan that barcode and fill out the survey. If you have any education that you want in the future, please put it in the comments. We love to be able to tailor these to needs in the surrounding facilities. And then if you have any questions, please reach out to me. Please reach out to Kelsey and Courtney. They're fantastic and they will get you to the right people. But I appreciate all of you being here and listening to us this morning, and I hope you all have a great week.
Jamie, I have the flyer, and I'll post that in the chat. Do you happen to have the actual link? I can ask Katie for it and post it in the chat later, but
I
I
do.
want to. Okay, perfect.
But
We'll get
I'll get
that
it.
added to the chat. Thank you so much. I will get everybody's certificates distributed out in either today or tomorrow.
There's the link, everybody.